Okay, I'm Dr. Betita and I've been tasked to lecture on analytical observational study designs. So by the end of this lecture, you should be able to define and differentiate between various observational and analytical study designs, understand the key features, strengths, and limitations of cohort studies, case-controlled studies, and case-control studies, explain how to select an appropriate study design for different research questions in medical practice, evaluate and interpret research findings from observational studies. So observational studies are those where the investigator just observes and does not carry out any intervention or action to alter the outcome. So walang intervention, walang binigay na gamot, walang binigay na anything, walang pinagawa, walang procedure. Okay. So study designs can be divided into two: your experimental studies and your observational studies. Um, Your observational studies include your cohort, case control, cross-sectional, and ecological studies. Your experimental studies, which will be handled in another lecture, include your RCTs and your non-randomized control trials. So descriptive observational studies are observational studies that collect information on the distribution of disease patterns in terms of the characteristics of person, place, and time. Researchers will simply observe and record information about something present in the population. Analytical observational studies, on the other hand, the researcher measures the exposure or treatments of the groups and assesses for association between exposures and outcomes. So the key word here is associations. So in analytical observational studies, you are trying to determine the association between one variable and another. Generally, hypotheses are specified in advance, new data are often collected, and differences between groups are measured. These are your measures of association. Okay. So the first type of study is your cross-sectional survey. This is a survey of a population at a single point in time. So the data is collected at a single point in time, and because it's collected in a single point in time, it's fairly quick and easy to perform. It's useful for determining the prevalence of risk factors, the prevalence of disease, the current health status, and planning for some health service, including setting priorities for disease control. The measure of association that is most commonly utilized for cross-sectional study is your relative risk. And later I will discuss how to go about getting the relative risk. This is the general schema of a cross-sectional study. You have a defined population, and the data on exposures and diseases are gathered at a single point in time. Exposures: exposed with disease, exposed without the disease, not exposed with disease, and not exposed without the disease. All of this is collected at a single point in time. The disadvantage of cross-sectional surveys includes no temporal relationship, because the data on exposure and outcome are collected at the exact same time. And because this data is collected at the same time, you cannot establish cause and effect. It is biased in favor of milder, longer-lasting diseases, and this is referred to as your Niemann or your late-hook bias or length bias. And it's inappropriate for testing the effectiveness of interventions. Kasi nga, you're getting the data at a single point. Okay? Walang follow-up na nagaganap. So cross-sectional ecological surveys, this is another type of research study design. They relate the frequency with which some characteristic and some outcome occur in the same geographical area. Okay, so basically when we refer to the same geographical area, these are a particular population. Okay, the unit of analysis in ecological surveys are your population. However, this is prone to ecological fallacy, where inferences about the nature of individuals are deduced from inferences about the group to which those individuals belong. And the measure of association that is used in ecological surveys are your correlation coefficient. Okay. And we have two types of correlation coefficient. We have your Pearson's R, wherein the data is numeric and quantitative, and your Spearman's Rho, wherein the data is ordinal and qualitative. So this is the general schema for a cross-sectional study. Your study population, controls and cases, exposed, not exposed, exposed, not exposed. These are all collected at a single point in time. Okay. So an example of your cross-sectional population is determining the incidence of colon cancer among women versus the relationship of colon cancer incidence per 100,000 women versus the daily meat consumption among different countries. Okay. So colon cancer incidence per 100,000 women versus the per capita daily meat consumption among women in different countries. And overwhelmingly, the highest colon cancer incidence occurs with higher meat consumption, and this is found among New Zealanders and Americans. Okay. Another type of study is your cross-sectional uh, longitudinal cross-sectional ecological longitudinal study. So this is another type of ecological study in which instead of comparing different populations, you're comparing the same population at a different point in time. So you have a single population and then you compare it at a different point in time. Okay, this is an example. This is the number of cases and deaths per day per 100,000 people from COVID. And these, the rates kasi were compared month on month and year on year. Okay, so what's the difference between a cross-sectional study and an ecological study? Um, Cross-sectional studies, the measure of association is your odds ratio, your prevalence ratio. They are quick and cheap to implement, and you can quickly establish associations. The major disadvantage of cross-sectional studies is an inability to establish causal relationship. You cannot use them for rare diseases or something where the prevalence changes rapidly. Your ecological studies naman, yung measure of associations, your correlation coefficient, it uses data that's already collected. It's relatively cheap and there are few bioethical issues kasi whole populations yung ginagamit. The major disadvantage is, and you're using data that's already collected. The major disadvantage is inability to establish causal relationships, and the associations found cannot be extrapolated to an individual level. Yung ecological fallacy natin. A cohort is used to describe a group of people who have something in common when they are first assembled and who are then observed for a period of time to see what happens to them. So in a cohort study, investigators begin by assembling one or more cohorts, such as persons exposed versus unexposed to a risk factor. Participants are then assessed to determine whether or not they develop the disease of interest, and the groups are typically divided on the basis of exposure and are followed up for outcomes. And the measure of association in a cohort study is your relative risk. Okay, so this just shows the difference between your prospective and your retrospective cohort. So in a prospective cohort, your cohorts are assembled in the present, and then the cohort is followed up in the future in order to determine if an outcome had occurred. In a retrospective cohort study, a cohort is assembled in the present based on past risk factors, and you collect data on present outcomes. And then you look at the patient's medical records to see when the exposure occurred. In a case control study, you assemble cases and controls in the present based on present outcomes and collect data on past risk factors, past exposures. When exposures occur that may be associated with outcomes, you look for these in the past. In a cross-sectional study, your associations between present exposures and present outcomes are obtained in a single point in time. Okay, so this is just the general schema for a cohort study. Your investigator is in the present, and he gets data on the population. He assembles his cohort and then follows up the patients in the future for their outcomes. In a retrospective cohort, your investigator is in the present. He assembles the cohort by exposure and outcome, and he looks back at through the patient's medical records to see when and where the exposures took place. Example of a retrospective cohort. The investigator uses historical data to define a risk group. For example, people exposed to the Hiroshima atomic bomb in August of 1945, and follows them up to the present to see what outcomes have occurred. In a prospective cohort, an example of a prospective cohort is a group of 10,000 healthy individuals recruited for the study divided into two groups, smokers and non-smokers. The participants are followed up for a period of 20 years to monitor their health status and the development of lung cancer. In a case control study, the investigator in a case control selects the case group and the control group on the basis of a defined outcome. So outcome yung nauna. In a cohort study, the exposure yung nauna. Okay. And compares the groups in terms of their frequency of past exposure to possible risk factors. The measure of association used in case control is the odds ratio. Case control studies are useful when a study must be performed quickly and inexpensively, when the disease under study is rare. Major disadvantage of a case control study is that it can only consider one outcome or disease at a time, but many risk factors can be considered. Disadvantages of case control study include recall bias. It may be difficult to identify the correct control group for cases. Your cases must be matched for controls, and there is a situation where you may have overmatching, wherein the cases and controls were inadvertently matched on some characteristic that is potentially causal, and then that cause will be missed. Okay, case control. An example of a case control is you want to investigate whether the use of oral contraceptives is associated with an increased risk of developing breast cancer. Your cases are women diagnosed with breast cancer, while your controls are women who do not have breast cancer. They're similar in other characteristics like age, reproductive history, and socioeconomic status. And you look back in time to see if either your cases or controls had a history of contraceptive use. Okay. Nested case control study is a subset of case control study wherein you start out with a cohort of participants. The participants are then followed up to determine if they develop the outcome of interest. Participants who develop the outcome of interest become cases, and participants who do not develop the outcome of interest become the control. So in a nested case control study, you start out with a cohort, and then eventually your patients will either develop the disease or do not develop the disease. Those who develop the disease are enrolled as cases, and those who do not develop disease are enrolled as controls. So an example of a nested case control study, the objective was to explore whether high school levels are associated with an increased risk of heart disease. A large cohort of 20,000 individuals is initially followed for a long period of 10 years to track their health outcomes and risk factors. Your cases were individuals who developed heart disease, and your controls were individuals who do not develop heart disease during the follow-up period, but were matched to the cases based on characteristics such as age, sex, and other factors. And your exposure is your high cholesterol levels. So you start out with a cohort, you see if they develop the disease of interest, and you look back if they had the exposure. Alright, so this is just a standard 2 by 2 table for showing association. Very important, disease status is here, and your risk factor is here. A represents a person who has the disease and the risk factor. B represents a person who does not have the disease and does not have the risk factor. B represents a person who has the risk factor but not the disease. And C represents a person who has the disease but not the risk factor. All right, make sure to memorize this table and how this is set up. Okay. Absolute differences in risk. So disease frequency usually is measured as a risk in cohort studies and clinical trials. An absolute difference in risk or rates can be expressed as a risk difference. The risk difference is the risk in the exposed group minus the risk in the unexposed group. So attributable risk is an estimate of the amount of risk that can be attributed to or is attributable to or caused by the risk factor. So attributable risk is simply the risk exposed minus the risk unexposed, and it's given by this formula. Example of attributable risk is the risk difference between smokers and non-smokers versus lung cancer. So smokers, the risk of developing lung cancer is 191 per 100,000. And for non-smokers, it's 8.7 per 100,000 in the US. All right. So subtracting the two risks, you get 182.3 per 100,000. So this is the risk difference between smoking and non-smoking in the United States. Relative risk, which is also known as the risk ratio, is the ratio of the risk in the exposed group to the risk in the unexposed group. If the risks in the exposed group and the unexposed group are the same, then RR equals 0. If RR is greater than the 1, then the risk is greater in the exposed group. If RR is less than 1, then the risk is less in the less in the exposed group. Okay. The risk of the disease in the exposed group is usually greater if an exposure is harmful, or smaller if an exposure is harmful. RR equals risk exposed over risk unexposed, and it's given by this formula. Odds ratio, this is the odds, it can be calculated by dividing the odds of exposure in the disease group by the odds of exposure in the non-diseased group, and it's given by this formula, AD over BC. In cross-sectional studies, the odds ratio is also referred to as the prevalence odds ratio, when prevalent cases are included, and instead of the RR, the prevalence odds ratio is calculated. The prevalence ratio is calculated. All right, so this is just a summary of the measures of association. So in cohort, the measure of association is relative risk. In case control, the measure of association is odds ratio. And in cross-sectional studies, the measure of association is your prevalence ratio or your prevalence odds ratio. Okay, this slide just shows the different tests that are used for the different types of studies. So we just want to emphasize that these are the preferred tests, okay? Whoops. So this slide just shows the different tests that are used for the different study designs. All right, so these are the equations for comparing risks in different groups and measuring impact of risk factors. So for purposes of completion, I will also be explaining your attributable risk percent, your population attributable risk, and your population attributable risk percent. Okay, so attributable risk percent answers the question among persons exposed to Y, what percentage of the total risk for outcome X is caused by the exposure? Your population attributable risk allows an investigator to answer the question among the general population, how much of the total risk for fatal disease X is caused by exposure to Y? And the PAR percent answers the question among the general population, what percentage of the total risk for X is caused by the exposure? Outcome X is caused by the exposure. All right, these are my references, and thank you for your time.